All right, first one. What's a vampire's favorite sport? What's a vampire's favorite sport? Basketball. All right, how about this one? What do you get with a tornado and a cow? What do you get with a tornado and a cow? No. A milkshake. Some of you are still in the Super Bowl mode. That was the worst play ever, but if you are a Seattle fan, I am so sorry. That was too bad. But, ouch, yeah. But that's not what we're here to talk about today. We're actually, if you look at the syllabus, we're in tissue repair, fibrosis, and healing. So we're in chapter 3 of the 8th edition. We have the 8th edition. And it seems like you guys are in the groove now on the pre-quizzes and the post-quizzes. So that's good. Any comments or questions before we get started, before we launch right into today? Today's going to be interesting for me because we get to leverage the background and inflammation that we've set up. And we're going to start talking about some very interesting, at least in my mind, applications of inflammation. So we're going to look at wound healing. That's really another word for tissue repair. Okay, it doesn't really matter where the tissue is. The tissue, a lot of times people think of wound healing and they think of a skin lesion. Well, that's true. Wound healing on the skin is absolutely true, but wound healing takes place in other tissues too. Wound healing happens in neural tissue. It happens in the heart. It happens in the kidney, in the spleen, the pancreas, the liver, or we can just go on and on and on. So wound healing is a sort of normal process that we as an organism benefit from, and it helps us to survive. If we didn't have any wound healing, then we would be compromised on a pretty regular basis. And we're going to look at the different types of wound healing, because not all wound healing is the same. And different tissues heal in unique ways. And then this word fibrosis, what does that word mean to you, fibrosis? Scarring, I heard it in the back. So fibrosis is a scar, and that is a component of wound healing that may or may not show up. So, for example, if you have an older lesion on your skin, like a cut from when you were a kid, there may not be a lot of fibrosis depending upon when you had the cut. If you were really young, say 5, 6 years of age, it may be hard to find where that cut was. But now that you're past adolescence, as adults, our wound healing as adults are much different than wound healing as a child. And wound healing as a child is actually different than it is embryonically. Embryonically is when you're in the womb and development is happening. And so we know that if you have a lesion or a wound in the womb, in utero, then why would that happen? Well, now medicine is advanced and we do surgery in utero on the unborn child, right? The field, And so for spina bifida, for certain types of diseases and pathologies, if we detect it early enough, we can go into the womb and we can try to correct it. And many times, depending upon how aggressive the surgery is, many times the child is born with little to no scar at all. And so it's been termed scarless wound healing. So embryonic wound healing is scarless wound healing. And there's lots of papers in the literature that talk about that. So that kind of becomes the holy grail in this field of wound healing, where scientists and physicians have been trying to figure out why does the body change from embryonic wound healing to adult type of wound healing. And as you get older into your senior years as geriatric patients, wound healing is compromised. So that's the full spectrum. Is in utero, it's the best. And towards the end of life, in your elder years, it's actually much more compromised. It takes longer. There's a more aggressive of a scar that forms. Okay? And so we're all kind of in between sort of that womb to tomb scenario. And you can probably appreciate, even where you're at in life, what wombs look like today versus what they looked like when you were 5, 6, 7 years of age. Okay? So we're going to apply some of the principles of inflammation as we walk through today's lecture. And I'm going to show you how they relate to this process of wound healing, otherwise known as tissue repair. So this is a graph that shows the general stages of normal wound healing. This is an older figure from 1996 from a textbook. It's a book about this thick, and the only thing they talk about is wound healing. And you saw this diagram, or a diagram much like it in our last lecture. We were talking about chronic inflammation, and we were comparing it to normal wound healing where you see acute inflammation. So in the stages of normal wound healing, this would be normal wound healing, you've got this early phase and you have a late phase of inflammation. That's not to be confused with acute and chronic. That's just your early phase are what cell types? Neutrophils. In your late phase, the guys that show up later are what? Macrophages. So there was a pre-quiz question about comparing and contrasting acute versus chronic, and macrophages are present in both, right? It's not that macrophages don't happen in acute inflammation. It's just they're the second responders, okay? So our early phase would be synonymous with neutrophil infiltration. Our late phase would be synonymous with macrophage infiltration. And you can see that they come up and they actually come down, meaning that they resolve. They go away after they're no longer needed. And then the next peak that you see, right, is what we call granulation tissue formation. Granulation tissue is usually a result of those macrophages that have come in. And those macrophages release all sorts of cytokines. And we talked about a lot of those cytokines, chemical signals that macrophages make. And many of them are what we call angiogenic. We talked about that term. What does that term mean? Angiogenic or angiogenesis. Making blood vessels. It literally translates as blood beginning, angio beginning, angiogenesis. Or angiogenic is something that stimulates the angiogenesis process. And these macrophages make these factors that stimulate new blood vessels to grow in granulation tissue. Why? Why do they do that? Why would it be advantageous to have blood vessels? Promotes healing. How? What's that? It's more stuff there. Let's use another term other than stuff. I agree. What kind of stuff? Oxygen. Okay. Nutrients. What else does it do? You have a vascular supply to a tissue. Do you only deliver nutrition? Do you remove waste products? You absolutely do. And in a healing process, you're going to have a lot of turnover of tissue. So you're going to have a lot of waste products from metabolic processes. Okay? So granulation tissue here, you can see it's important. But it comes up and it resolves as well. So if any of these peaks were to stay elevated and persist, that would not be indicative of an acute response or normal wound healing. Any of these peaks that tail off and stay elevated are not considered normal. Then from phase B, if you will, you get this peak coming down, and this is where you've got tissue remodeling. You've got the tissue, primarily the fibroblasts in that tissue, are going to start manufacturing replacement extracellular matrix. Specifically, a lot of collagen. And as they make collagen, that remodels and that patchworks back the damaged tissue. Remember, a tissue is two main components, right? It's cells and matrix. And so the cells will proliferate and regenerate if they're able to. But the matrix environment themselves, that the cells live in, that also has to be recreated if it's damaged. And so that's where the collagen remodeling takes place. This continues on for a period of time. And from about where granulation tissue starts to fade off is where you get resolution of inflammation. So in order for normal wound healing to actually happen, you need to see all of these phases come up and come down. And if any of them stay elevated or don't resolve, would be the word we would use, then it would be considered normal. Okay? It would be an abnormal healing event. And most classically, you would see inflammation persist. And you wouldn't see this phase D where you have this resolution of inflammation. Okay? So it's a little bit of review from what we talked about last time we were together. But it's relevant to this question that I want you to work on. Someone explain the difference between resolution and repair to your neighbor. And the other one explain the difference of healing, first versus second intention. Okay, let's hear some ideas. Who can help explain the difference between resolution and repair? Yes.
Resolution is when the skin turns back to normal and there will be a scar formation, like fibrosis, as in repair, and the cell will be returned to a normal function. Resolution when repair.
Yes, exactly. You guys all hear that? So resolution is where you have the tissue turning back or regenerating to return to its normal function. That's kind of the big necessity. For resolution to happen, another word for it would be regeneration, where you get the complete restoration of function, whatever the tissue is. Okay, so for example, if it was cardiac tissue and you had damage to the myocardium, remember 202, then you would, and this doesn't happen by the way, that's why we have issues with heart attacks. But those myocytes, those cardiac myocytes would reproduce, regenerate, resolve the wound, and function of the heart would be restored back to normal. And cardiologists and cardiothoracic surgeons would be out of business. So we know that that doesn't happen, right? In contrast, also well described, repair. So not all tissues can resolve a wound or can regenerate after a wound happens. And so you have a secondary process known as repair. And in repair, you actually see the replacement of functional tissue with scar tissue. And that scar tissue doesn't look like the original tissue. It doesn't behave like the original tissue. It doesn't feel like the original tissue. It is a patchwork to kind of fill in the void space. So the analogy would be, have any of you driven on the roads here in town lately? This is about the time of the year that they become really bad. Okay, because you know, the budget is a struggle, and it's expensive to resurface a road. So instead of stripping the whole road down and laying down all new asphalt, nice and smooth with no defects, they come in and they fill it in with just patches. Well, then water gets in there and freezes and it lifts the patch out, Now you have a pothole again. So resolution would be if you strip the road down and you laid it fresh. And repair is, there's a pothole, I'm just going to stick some hot asphalt in it, pack it down, and stomp on it and call it good. And you can tell a road that has been done well versus a road that's just been patched. Even if the potholes are filled, that repair process, you can see exactly where the defect was, even if there was appropriate amounts of asphalt put in there, and even if it was rolled down, you know, with those big rolling machines. Okay, so our body has two main ways that we modify tissues after damage. First one is resolution, complete regeneration. The second one's called repair. All right, second question. The difference between first and second intention. First and second intention. Any ideas?
You're thinking about it. First intention would be just like a small sort of damage, and it generally leads to resolution. But
Okay.
second intention would be much more severe damage.
Okay. Yes, there's more you could add to that. That's not incorrect. That's correct. First intention is usually a smaller wound. Second intention is usually bigger, but not necessarily always. So what else? What other details can we add to help out? That's
Is it first intention, like a surgical, clean cut, and then second intention is more traumatic?
yes. So first intention tends to be more of a precise surgical incision, and second intention usually is based upon trauma. So if I was to draw the shapes or the different architectures, right, that would be first intention, where it's a scalpel blade, and this piece of tissue and that piece of tissue we can actually approximate. Okay, that would be the word, is you would approximate those two pieces of tissue and you could line them up real nicely. Okay, like wrapping a present with patterned paper, and you take the time to try to match the pattern up. Some of you are like, people do that? Like, yeah, you know, some people do that. Okay. Second intention, so this would be first. Second intention would be something that would be more traumatic, where you would have a piece of tissue and you'd have large gaps between 1 and 2. And because of the trauma, this would not be a clean edge, and it would be difficult to approximate those two edges. Now, as was previously said, first intention usually, because it's a surgical clean cut, it's usually smaller. Again, there are some large surgeries. Okay? Traumatic wounds would be, you know, like falling off a bike or a motorcycle accident. Okay? Or slipping and falling, or a car accident. I mean, wounds that happen based on trauma don't have nice clean edges typically. Okay? So first intention is usually the repair of a clean, uninfected surgical incision. And the wound edges are approximated by sutures or staples or surgical glue. Healing by second intention usually is larger. You have a very aggressive clot that forms because you need something to fill that gap. You have a more intense inflammatory response because you have more tissue that's actually traumatized or damaged. You see more granulation tissue, which is what happens as a result of macrophages coming in. And once you have epithelialization, or the wound repairing, you likely will see aggressive amounts of scarring or fibrosis.
So say I break my femur and the doctor says it's a clean break, would that mean it's going to heal by first intention?
No, not necessarily. They're usually referring to the type of fracture, whether it's a spiral fracture or if it was a compound fracture, hairline fracture. So that a break, meaning a clean break, is, you know, if it's not a compound fracture, it's always clean. Compound fracture is one where it's poking out of the skin, so then you can have infection coming in. But if it's not a compound fracture, then there's no risk of bacteria getting there.
Will you ever see resolution in the first intention wound?
Will you ever see resolution in a first intention wound? Yeah, oftentimes. I mean, maybe in shades of resolution, right? I mean, so for example, let's take the skin. Let's say that you had a wound that was like this, and you weren't happy with the way it healed. Okay, you could go in and get the scar revised. You ever heard of this? So you go see a plastic surgeon, and they're going to try to make the aesthetic appearance of that wound better. How do they do that? Well, what they do is they try to take this and make it this. So they'll come in and they'll surgically create two clean edges, and they'll bring those two clean edges together, and they'll revise the scar or the wound or lessen it by promoting a first intention type of healing. Okay? So that's what the plastics guys are great at that. And a lot of times it happens when you have injuries on the face, just because it's the aesthetic zone. You know, if it's on your elbow or your knee, probably, you know, a waste of money. But, you know, there are patients that have aggressive procedures or aggressive traumas, and after it's done, there is an opportunity to do a revision to the wound based upon this principle of, if I create a cleaner site and I can approximate the tissues in a better way, I can probably have a better aesthetic outcome. Okay? That's a good question. All right, so let's take a look at a different type of roadmap, or a way to look at these two classifications of healing. So at the top you see a cell, and it's being injured right underneath here. There's an injury. That injury can be just about anything. Well, that cell that's injured can go one of two directions. It can go down this regeneration path, which we also refer to as resolution, or it can go down this healing path, which we also refer to as repair. We know that in regeneration, for example, you have renewing types of tissues in our body. So there's examples that we have where we get complete regeneration on a regular basis. And those cell types do become injured because they age and they turn over, and the body gets rid of them, and it replaces it with a new tissue that's completely functional. So there are complete regenerative tissues in our body, like, for example, the skin, the GI tract, okay? The blood system, the hematopoietic system. So the skin that you have today is completely different than the skin you were wearing 3 months ago. But it looks essentially the same, and it functions essentially the same. Now we know that as we age, that organ, the skin, loses some of its functionality. What do you mean? Well, if you look at the skin of a 2-year-old baby, and you look at the skin of an 82-year-old individual, their skin looks very different. One of the functional things that's gone is the elasticity of that skin. And if you look microscopically, you would see a slower wound healing response in that 82-year-old versus that 2-year-old. Okay? But we, generally speaking, throughout the phase of our life, have the ability for complete regeneration to take place. There are other organisms that do this with more than just those three systems. Right? Like the newt or a salamander can regenerate limbs from a limb bud. You guys have probably seen lizards who lose a tail and regenerate a tail. Okay? There's certain types of salamanders that have the ability to regenerate cardiac tissue. Okay? So why don't we? I don't know. I don't know the answer to that. Okay? But we do regenerate certain tissues, and we do it quite well. Now, there are some stable tissues that aren't necessarily renewing, like this great example. But, for example, you can look at the liver and the kidney, where you could lose a dramatic or a large component of these tissues, and they would have the ability for compensation and even some additional growth. So, for example, if you, let's say, lose 2/3 of the liver, well, the 1/3 that's left over can regenerate. It won't regenerate completely. You can see that it doesn't completely regenerate, but it will regenerate enough to compensate for the lost tissues. So organs like the kidney and the liver can do that. And we'll talk about these two organs specifically later in the semester when we get to renal function and pathologies, and we get to liver function and pathologies. So these are the examples of resolution. Now over on this side, this is more commonly found throughout the body after embryonic development. This is what we usually see. These are more of the exceptions. Over here, we see a wound, and we see the wound healing and then a scar that takes place. And it fills in the gap, but it's shaded a different color because the function of that tissue is very different than the native tissue. If we talk about what we looked at last week, chronic inflammation, if we have chronic inflammation that persists, then this is going to stimulate a very aggressive fibrotic response. And you may lose complete function of that tissue altogether. In some extreme cases of liver fibrosis, when the compensatory mechanisms can no longer work, you see fibrotic liver, or what we call a cirrhotic liver. And that's an excessive example, but that is an example that we'll talk about. Okay, so cells and tissues are made up of cells and matrix. So what does the fibroblast do during the reconstructive phase of wound healing? And of course, in the context of second intention. Number one, does it regenerate new capillaries from vascular and endothelial cells? B, establishes connections between neighboring cells and contracts their fibers. C, synthesizes and secretes collagen and connective tissue proteins. D, provides enzymes that debride the wound of the cells, or two of the above. What do you guys think? C, synthesize and secrete collagen and connective tissue proteins. I agree. There's another correct answer there, though, too. Which one? B is in boy, also. Establishes connections between neighboring cells and helps contract their fibers. So that's where you get your wound contraction taking place. Anybody have a question about what the word debride means? Or debride, depending on how you say it. Everybody knows what that word means. It's in question D, or answer D. So this is a word, debridement or debridement, is a word that's referred to, or is used within wound care, where you remove a lot of the dead tissue. Nowadays, the way that we do that in the clinic is usually with physical, mechanical abrasion. So you'll come in and you'll rinse it out with saline, and they may actually kind of scrub the wound down and clean out the dead tissue. They may actually cut away surgically if there's a really large area of necrotic tissue. So it's cleaning away dead tissue. In older medicinal cultures, you've heard of maggot therapy. Has anybody heard of putting maggots in a wound? Well, so these maggots feed off of necrotic tissue. They do not touch living tissue. So if you've ever watched one of these, action movies and they're in the jungle or something and they get a big wound, they pack it full of maggots. It's doing the same thing. It's actually cleaning away the necrotic tissue to get down to the clean tissue so that the wound healing can take place. So it actually does work. Okay, I'm not sure Medicare loves it, but it totally works. Okay, so that's what that word means. Two of these would be the best answer, B and C. So in the theme of a tissue having both cells and matrix, we could see examples of wounding in the liver, or wounding in the kidney, or wounding in the skin, where you may only impact the cells. How so? Well, you may have a loss of blood flow temporarily. And if that loss of blood flow stuns the cells and the cells die, but the matrix remains intact, in many of these tissues, those cells that can regenerate will repopulate the tissue and you'll get a better outcome. if the ischemic episode is so long and aggressive that you lose the cells and you actually start destroying matrix, now you have to come in and rebuild the matrix, and you have to repopulate the cells. So it's a worse outcome. Scarring is much more aggressive if you have cells and matrix that are damaged. So take a look at this picture. This is regeneration of the liver. So the liver is an example of one of these organs that I told you about that has a tremendous regenerative potential. And so it's used as a lot of our examples. So here's our normal hepatic lobule. You can see this little black inset. That's it in higher magnification. And then here is another black inset. And these are higher magnifications of that view. So from here you're zooming into there. From here you're zooming to there. Does that make sense? So you can see the portal triad, where you've got the bile duct, the hepatic artery, and the portal vein in both of these images. And so here in this image, you see just injury to cells, meaning you see the architectural framework underneath is pretty much intact. Then when you proliferate the cells that are remaining, the residual cells, they go right back into where they're supposed to be, and you get restoration of function. Well, over here, if you have injury to the liver and you lose the matrix architecture, now you have a worse outcome, really repair by scarring, versus over here where you had complete regeneration. Because now you've actually had to recreate the architecture of the matrix for the cells to live in. And when you do it embryonically, it turns out exactly the way it's supposed to be. When you do it post-embryonically, then it's a little bit more unorganized and more random. And that's why the scarring that you see on that big lesion on your arm or your leg or your back or wherever it is, if it happened post-embryonically, it's probably more aggressive scar. Okay? So the take-home message here is different levels of wound healing based upon what's damaged in the tissue. Is it just the cells, or is it the cells and the matrix that are both damaged? If it's the cells and the matrix that are both damaged, you're going to see repair by excessive scarring. If it's just the cells and it's a regenerative tissue, you may see complete restoration of function.
At what point does embryonic healing stop?
When you're born. It switches the moment you take your first breath. It's no kidding. So I was working for a company years back, and we were really focused on this embryonic healing. And what the literature and what we discovered were there's a whole series of genes that turn off and turn on the moment that you're born. Because the embryo is actually in a hypoxic environment. It's developing in suspension, so the cells are floating in suspension, which is like a low gravity type of example. They're in a 3D environment, and they're hypoxic. And when they're hypoxic, there are certain genes that are upregulated. One's called HIF1 alpha, hypoxia-inducible factor alpha, just in case since you asked. And it turns off the moment the infant takes the first breath and starts screaming. The gene shuts off like that. It's pretty nuts. Yeah. So there are cells that HIF1 alpha turns off more slowly, but for the most part, HIF1 alpha shuts off immediately as soon as the oxygenation. It might not be the first second, but as soon as the oxygenation levels of the infant come up to what we all experience, the gene profile totally changes. But in utero, where is the baby getting the oxygen from? It's stripping it off of the maternal hemoglobin, right? So the embryonic hemoglobin has a higher affinity for oxygen than the mother's hemoglobin. So they literally strip the oxygen right off mom's red blood cell. And that's where they get their oxygenation. But mom's perfusion has to keep her alive and has to keep the developing infant alive. The developing infant, the embryo, is actually hypoxic. So there's all these factors that are running in a hypoxic environment, which is what we believe, the field believes, is the key to having the scarless healing. So this company was taking cells and growing them in an incubator under hypoxic conditions in suspension to turn on embryonic signals, and then we would see wound healing associated with embryos versus adults. Kind of cool.
Is there like a large need for embryonic healing? Like, are they experiencing like a
wounds like when they're in the womb, or
No, it's a byproduct of normal development. So the question was, why does the embryo have such a great ability to heal? I mean, are they like turning around and bonking their head everywhere and getting these wounds? No. But it's a byproduct, it's a side effect of the tissue being super regenerative. Because they're in a phase of, you go, in 9 months, you go from 2 individual cells to an entire organism. Think about all of the processes that are taking place. Those cells have to be really well versed in being able to proliferate, regenerate fast. And so this is just a side effect. Okay, last question, then I gotta go on.
Can we get the same scarlet wound healing with induced pluripotent stem cells?
Yes you can. Can you get some of the same scarlet wound healing with induced pluripotent stem cells? Yes you can. And you can get them with embryonic stem cells. We're going to get there in just a minute. Okay, so hold on. Okay, so let's talk about, that's the matrix of the cells. You also know that there are certain cell landmarks that are critical. So we're not going to spend a lot of energy on this, but I want to remind you of where you've studied in previous classes. And all of these cells in our body are subjected to these normal cell cycle landmarks. So just to refresh, right, we have these gap phases. These gap phases like G0, G1, and G2. And in these gap phases is where the division actually pauses for a moment. And we'll see later in the semester when we start talking about cancer, specifically this G1, gap 1, there are certain genes that code for proteins that cause G1 to be enforced. That means that they encourage G1 to last a little bit longer, so that the cell can take a moment to check the integrity of the DNA before it does a replication. Okay? And what cancer does is a lot of times cancer gets rid of these gap phases. And so there's no pause. It just continues to replicate again and again and again. And is probably replicating something that's not normal. And we'll talk about that in the cancer section. But we'll come back to this particular cell cycle slide in the cancer lecture, or we'll refer to it, because cancer is just your normal cell, but it's gone astray. It's not operating under the normal checkpoints or signals that prevent it from acting in this abnormal way. So the gap phases, then you have this S phase, the synthesis phase, and then you have the mitosis phase, and you get cell division. And so fibroblasts, in most tissues in the body, you have fibroblasts. They're the ones that make this collagen. They're the ones that can proliferate and divide. They have tremendous regenerative potential. Okay? In my laboratory, we have students growing fibroblasts. They're an easy cell to work with. They have a doubling characteristic that's very quick. They don't tire out very fast, meaning that you can pass them for many, many, many passages. What does that mean? Well, you harvest them at what we call passage 0, and then you let them replicate, that's passage 1. You let them replicate again, that's passage 2. You can do that in culture for up to 12 times, and they won't even poop out. Once beyond 12, you start thinking they're tiring. But that's outside the body in a petri dish. They can do that. In the body, they don't typically poop out after 12 cycles. Does that make sense? But this is this byproduct of an artificial environment in cell culture. They only last for about 12 doublings. So all the cells go through this cell cycle and these checkpoints, and they have these general patterns of intracellular signaling. So you probably have talked about these in previous classes, but we're going to go over them. We have what we call autocrine signaling. Autocrine signaling up top on the left. This is where the cell itself is going to release some sort of signal. That signal is going to bind to a receptor on that same cell. And then it's going to cause some physiologic activity. We'll see this autocrine type of signaling when we get into the immune adaptive section, the adaptive immune or specific immune system, where we start seeing signaling happening when these cells are being activated. Paracrine signaling, we'll also see that in our immune section. We've got a cell that releases a product, but it targets or it binds to a target cell that has the receptor for that particular cytokine or that signal. That would be called paracrine. Para like perimeter. That's a nearby or an adjacent cell. Autocrine, auto, self. It's the same cell. And then the last one utilizes the vasculature or the lymphatics. And you release the products into the circulatory system, and then it perfuses throughout the body, and it has recognition sites on distant cells. But this way, you actually get a more broad effect. An endocrine effect means it uses the endocrine system. It's going within the body to all over the body. And endocrine activities that we'll see when we look at our endocrinology disorders, like things with the thyroid, things with pancreas, things with the pituitary gland. Okay? So 3 main ways that these cells actually will interact. Now we kind of put these together. We have the cell component and we have the matrix component. And we're slapped with a super busy slide. So let's take a moment to look at this busy slide, and then we're going to have just a few more slides that are going to mechanistically kind of shape how this all is put together. So this is a blood vessel right here. This little Y branch structure is a blood vessel. This is an epithelial surface, and it has a basement membrane that these are attached to with integrins. Okay? And then outside of the blood vessel, and deep from this epithelial border, you can actually see that there are tissue fibroblasts. Those are these spindle-looking cells. And if you look carefully, you can see in the background is sort of this stringy architecture. So cells don't just like hover. They actually have to exist in a matrix. They have to have an environment that they attach to and grow on. So the analogy I like to use is kind of like the old school jungle gyms. I don't know if you remember those. They don't make them anymore. Now, you know, everything's out of like recycled tires, and they have shades over them, and you know, you have to sign a waiver before your kid walks in. In the old days, it was all metal. You know, down in the valley, the slide was made out of metal. And you just learn not to put your bare legs on it, otherwise you have to have a skin graft. You know, and the prince will be like, "Well, I guess you're not doing that ever again, huh?" That's what we do here. We teach you things. So, what was I talking about? Oh, the old school jungle gym, right? It's like this. Sorry, it's like this dome structure, and it's got, you know, bars going everywhere, and the kids, you know, fall off and break arms all the time, right? Just like the old days. So the cells are like the kids crawling on this architecture, and the matrix is like the jungle gym. So cells don't just hang out in space and float. They actually have to physically attach to something. So that's what this is showing you, is that these fibroblasts are in this matrix environment. In fact, right here is a blow-up, and you can see this fibroblast, here's the nucleus, like a normal cell, regulated by that cell cycle. It is physically connected to this extracellular matrix environment. It is the jungle gym. And look at all the things that you can see in here. The integrins connected to the matrix itself. And you've got adhesive glycoproteins, or proteoglycans. Those are sugar-coated proteins. You actually have collagen triple helices, right? You'll have laminin here. You'll have elastin. You'll have all sorts of different fibrous structural proteins that the cells are going to attach to. And if you push on the protein architecture, it's physically attached to the fibroblast, so the fibroblast could respond to that. And the fibroblast could respond to that because that mechanistic signal is transduced into the cell, and the cell has a cytoskeleton architecture made up of actin and other things. These are all the things that are invisible that we don't spend a lot of time thinking about, but the cell doesn't just float in space. It actually physically attaches to the matrix. There is a slight difference between interstitial and extracellular, and it's a little bit of difference between one tissue type and another. So like the extracellular matrix that you would find in the skin is going to be a slight different organization than it is in the heart. And it's going to be a little different in the kidney. And it's going to be a little different in the liver. Make sense? And so if you look at this matrix right here, and you look at the basement membrane, this is also a matrix. Both of these would be considered extracellular types of matrix, but the architecture here is very different than the architecture here. Here you actually see the lamina is like this cross-looking structure. You see type 4 collagen, you see the proteoglycans, but in the basement membrane, it's more like a sheet. You see how these are like sheets on top of sheets? And out here in the interstitium, you see that these are just more of a random woven pattern. Okay? Both are considered extracellular matrix because they're outside the cell. But the basement membrane is organized in this fashion, and the interstitial matrix between the cells here is organized more randomly. So that's a great question. Depending upon where you are in the body, the matrix is going to have a different shape. It's going to have a different architecture. Not all matrices are the same. So we talked about this matrix. We talked about this matrix. We talked about this cell. And that is the blow-up of this guy. This is the blow-up of these two basement membranes. Okay? So if you had damage to the skin or the tissue right here, you would recruit macrophages and neutrophils out of the circulation to that area to kind of clean up that environment, and then you would stimulate these fibroblasts to proliferate, and you'd stimulate them to lay down new matrix. Make sense? And that's if it's in the skin, that's if it's in the heart, that's if it's in any organ, fill in the blank. So the fibroblasts are connected physically to the matrix. They don't just hang out in space. And one can influence the other. So if you look at this particular slide, this is showing inside the cell. Here's the nucleus. The nucleus is physically attached via these actin cytoskeleton filaments to these FACs. Those are focal adhesion complex. Those focal adhesion complexes are physically connected to integrin molecules. They usually have an alpha and a beta subunit. You can see the alpha and the beta side. These integrins, they integrate the cell to the outside environment. That's what they're called, integrins. And you can see how they do that is here's a collagen triple helix. It's looking like this blue spaghetti stuff. And the integrins themselves, and this is fibronectin, physically attached to the extracellular matrix, which links the inside of the cell to the outside of the cell. So the nucleus is getting signals from the outside about proliferation, differentiation. It's getting signals about, should I attach, should I migrate, do I need to move to a new area? So all of the outside events are affecting the inside nucleus. So when we study cell biology, we tend to focus very heavily on the inside contents of the cell. And rightfully so, it's fascinating. But there's a whole other field of extracellular matrix biology. And those people would argue that the most important thing is the outside environment and not the inside mechanics. Who's right? Well, they probably both are, because you can't have a tissue without both. Okay, but folks that are cell biologists are really heavily interested in the inside of the cell. And the extracellular matrix biologists are fascinated with the outside of the cell. And there are two different ways of looking at the tissue. Does that make sense? Because all tissue is made up of cells and matrix. And the cells are unique to the tissue, and the matrix is unique to the tissue. The matrix in the heart and the cells in the heart are completely different than they are in the liver.
In the interstitium, is there anything organizing the matrix, or is the fibroblasts just kind of spinning protein?
So the question is in the extracellular matrix that's between cells and the interstitium, is there anything organizing the matrix? Yes, there is, but most of that programming happened during embryonic development. And so if it's a wound healing event later on, then the fibroblasts do a more random, less similar. In fact, what happens in skin is instead of making one type of collagen, you make a different type of collagen. Does that make sense? So you still make collagen, but you make a different version of collagen than when the tissue was originally formed. I don't know if there is a benefit. I think that my theory, and this is me theorizing, is that that original collagen that you made, the gene has turned off or is shut down in production level because of the embryonic changes that take place, primarily because of ischemia or hypoxia. And then in replacement of that, you make a different form of collagen that's easier to make.
That does compare embryonic to adult or
Yeah.
adult?
That's embryonic to adult.
Okay.
Yep.
So
Embryonic.
child to adult, you have the same.
So, I mean, there's a lot of them that turn off right away, and then some of them kind of gradually turn off as you get older. So, the biggest difference or comparator would be embryonic versus adult. How do you classify adult? After you're done growing. Yeah. So, I mean, you know, I have kids, and my young ones are 5 to 12, and, you know, they have all sorts of cuts and scrapes and things like that. And I can definitely tell a difference between the wounds that happened on them when they were younger versus the wounds that are happening now. Yeah.
So what if, like,
And I'm not like making the wounds, just so you know. I'm just observing. It's not like, you know, wah.
so what if I got it coming out of it because it's collagen and you kind of have your own?
Yeah, it would be adult-based collagen now. Yep, all of us are in the same bucket, same category. Some of us just a little further along than others. Well, so part of the why might be behind the scar wants to create a really mechanically sound material structurally. So it's going through the energy of trying to patch, you know, a hole, and so it's going to do it maybe overly aggressive, and that's why it looks it's not very stretchy. The other reason is elastin. Elastin is a protein that gives your skin or your organs its stretchiness. And the gene for elastin starts shutting down between the ages of 10 to 13. So by the time you're in this classroom, you no longer make elastin. Does that make sense? So elastin has a half-life, though, of about 70 years. So you know, once you're done growing, you just need to repair the tissue that gets damaged. You don't have to make a whole new bladder. You don't have to make a whole new blood vessel like the aorta. Okay, so there's no real need for the body to continue to make elastin once all of these major stretchy organs are made. It just needs to repair holes and patches. So if you look at the aorta of a 70-year-old and the aorta of a 7-year-old, the aorta of a 70-year-old, our aortas continue to dilate as we get older because we lose elastin content. Another example would be the skin. Look at the skin of a 70-year-old versus the skin of a 7-year-old. There's no more elastin really. Or they're at 70 years of age, there's about half the elastin in the skin as when that individual was born. Okay? But elastin is not just in the skin. It's in the bladder. It's in the heart. It's in all of the blood vessels, the major blood vessels. Anything that has elastic recoil has elastic component. People have looked into how you can turn on elastin expression in tissues later in life, but nobody's ever been successful yet, that I'm aware of. Okay, angiogenesis. So these cells in these tissues have to replicate or reproduce in order to fill in these void spaces. But another thing that's important is this development of a new blood supply. And we've talked about angiogenesis a few times, but here's kind of a big definition of it. You can see a vessel on the far left and a sprout. And you can see what that sprout can do in creating a new capillary bed. And then it can actually mature. You can actually recruit smooth muscle cells and actually cause a maturation of that new vasculature so it doesn't regress, it doesn't go away. And the reason that this is important in a wound healing process is like what we talked about before. You want to bring in nutrition, and you want to have an ability to remove waste products. If we look at wound healing by this first and second intention again, and we characterize it based upon a couple of features, we can hopefully see some major differences. So this is a thin wound. This would be healing primarily by first intention of a very thin wound. You have a minimum or a minimal amount of clot formation. You still have neutrophils coming in, followed by macrophages. This is 3 to 7 days here. This is within the first day. And then weeks later, you get this fibrous union that takes place. And you see that there's very little disturbance of the surface, not much scarring. Okay, so healing by first intention may have no scar to minimal scar. It may not be that there's 0 scar, but it's going to be minimal. Look also what happens with the vasculature in this process, because we just came from that angiogenesis slide. You can see that these neutrophils and then the macrophages that come in are going to recruit new vasculature to develop in order to clean up this wound area. Once it's done, the vessels actually regress. They're no longer needed. So they actually go back to somewhat normal versus this aggressive growth of additional vasculature. If we contrast that by second intention, you can see this is a much bigger wound. It can be considered a traumatic wound. And you see all of the same phases that we looked at before, but look at how aggressive the macrophage infiltration is. Look at how aggressive angiogenesis is, much more pronounced. And then at the end, you get a bigger wound retraction, or wound contraction, because the wound was larger. So now at the surface of the skin, you see this little divot, and you're going to see this fibrosis. And that skin is going to behave very differently than the skin next to it, or the skin that we would have seen with first intention healing. Okay? Yes?
So even if the capillary beds were to mature, would they still go back to...
If the capillary bed's mature,
yeah.
then they are the body has decided that it needs it there. So if you get maturation of the capillary architecture, it probably won't regress. But if this happens, that means that it didn't stick around long enough for aggression to take place. Or for maturation to take place, excuse me. So here's a skin ulcer. This is from a diabetic foot ulcer in a patient struggling with uncontrolled, chronic, unmanaged type 2 diabetes. Yes?
In what instances would the capillary bed become maturity? So why would the body decide that it's mature?
So in chronic inflammation, you would have long-term angiogenesis that sticks around, and it wouldn't resolve. Okay? So this is a pressure ulcer, commonly found in diabetic patients. This is the ulcerated tissue. We're going to look at some histology here in a second. That's the macro view, or the gross view. If we look at what it looks like histologically, then you would see something that looks like this. Right, here is our underlying tissue. That's actually granulation tissue. You can see the edges. This is the epithelial edge, and this is the epithelial edge. Now, this is a skin ulcer with a large gap. If it's in a diabetic patient and it's chronic, then it's going to stay like this. It's not going to close off. If it was in you and me, if we had a major blister from a long hike, and we weren't struggling with like type 2 diabetes or any wound healing issues, then we're going to see the next phases that I'm going to show you of this healing process take place. Right? We're going to go from this, you and I would go from this to something like this. This is an example of where we've got reepithelialization where the wound edge has been covered at the top. You have extensive granulation tissue from the inflammatory response that recruited all these macrophages in the area. They're making all of these angiogenic growth factors, and that's creating new blood vessels. How do you know they're new blood vessels? Well, let me show you. This is a cross-sectional view of a blood vessel. Here's one. Here's one. There's actually 4 red blood cells inside that one. Here's a blood vessel. There's a blood vessel. Do you see them all? This is all granulation tissue. Here's a red blood cell right in the middle of that capillary. Here's a blood vessel right here. So this is classic granulation tissue. This would be a part of normal wound healing as long as it didn't stay here. If it stayed here, or if it stays here, not normal wound healing. If it progresses from that previous picture to this picture, we know that the wound is starting to heal. And then eventually what we would get is something like this, you and I. In healthy patients, you would progress to this level, where now you see restoration of the stratum corneum. That's the topmost layer of the epidermis. You can see the basement membrane and this connection between where the epidermis meets the dermis. This is all the underlying dermis down here. And you can actually also see from the pink, you see the areas, the bands of kind of pink eosin staining. That's all new collagen. And so that collagen is starting to contract the wound back so that you don't have a large defect at the surface. Now, in some patients, I think the question was asked a little bit earlier, in some patients, we get different degrees of collagen production, different levels of collagen production. So some of us, for example, we get a wound and it heals very well, and we're fortunate. In other patients, they get a wound and the collagen response is very aggressive. And this excessive collagen response leads to what we call a keloid. And there are certain patients that are prone to keloid formation. What it is a very aggressive wound healing response with excessive amounts of collagen being produced. Okay, this is what it looks like grossly at the surface of the skin. Okay, that's just extra collagen. If I took a histological section of that, you would see in these arrows pointing to those regions of heavy eosin stain that are identifying in the wound where those areas of excessive amounts of collagen are. And you kind of appreciate, if you look across the surface, this is where the skin kind of bubbles up, giving rise to these types of structures. Okay? So this is what a keloid would look like histologically. On the previous slide is what it looks like grossly. Questions?
So what would cause it to produce excess collagen?
The genes are coding in the cell. The fibroblasts, the genes in the cell say, okay, when I do a wound healing event, I go through this mitotic cycle 70 times instead of 10. It's just the genes are running collagen production more than they are in the next person. There are some people that don't make enough collagen, right, in their wound. And then the wound itself and the scar is really, really delicate. And it's not appropriate. So you have both sides of the spectrum. I don't have an example of that histologically, but both sides of the spectrum do exist.
Type 1 diabetic patients get ulcers too.
Oh yeah. They get ulcers. Type 1 diabetic patients can get ulcers if it's unmanaged.
What causes that?
So we'll get there, but the ulceration that takes place is a result of poor perfusion of tissues. So why would the tissues not be perfused well? Well, when you have high amounts of sugar in the bloodstream, those sugar residues actually cause a lot of damage to the inside of the blood vessel, and that creates vascular lesions, and that leads to a narrowing of the vessel, and that happens primarily down here in the lower extremities or in the arms, and then it decreases blood flow to the feet. And then what happens is they step on a carpet tack, or they get a blister, and it never ever heals. And it gets infected, and then they have to either lose the toe, or lose the foot, or lose the lower leg. And that can happen in both types of diabetic patients if it's unmanaged. And what that means is they're not paying attention to their glucose levels.
In CNA courses, they talk about like pressure ulcers from patients like in hospital. Would those ulcers heal differently than a diabetic patient?
Well, so a pressure ulcer,
Yeah.
an ulcer is an ulcer, right? An ulcer is basically just a wound that isn't closing off. And so the pressure ulcers that patients with bed sores, for example, or patients that sit in, are confined to a wheelchair for too long, they're not moving around enough, there'll be an area of the tissue that is underperfused because it's not getting blood flow. And so that leads to an ulceration that takes place. So it's a similar process. it can resolve, you just have to increase blood flow to the region. And there's all sorts of different strategies on how to do that. We have wound vacs now. A lot of physical therapy and occupational therapy is about rotating the patient, make sure they're not in bed too long, get them up out of the wheelchair, try to, turn them over, do dressing changes and things. But it is unfortunately a very common side effect for patients that are either bed-bound or wheelchair-bound. And even if they don't have diabetes, just they have other comorbidities, and they're not struggling with diabetes, and they'll still get pressure ulcers. Let's take a break, and then we'll come back and talk about stem cells.